Great, thanks so much. It's a treat to round out. This has been a really informative, somewhat sobering, but informative session. And what I'm going to talk about is kind of touching on some of the topics that have already been mentioned, but perhaps using another approach to kind of resolve some of our difficult cases, and that's using CT. So my disclosures. And for those of you who, of course, are familiar with coronary CT, it might have not been obvious, but for CTOs, this is particularly useful because coronary angiography, X-ray angiography, cannot fill contrast into the body of the CTO, whereas CT itself can see the vessel wall, certainly calcium, and identify the course. It can help us with proximal cap ambiguity, understanding tortuosity, and doing a much better job to understand calcification, whether or not it's focal or circumferential. And when we don't really appreciate these factors, we can sometimes get into very difficult situations in understanding what our true anatomical courses are and leading to a higher rate of complications. So it's actually been shown that if we look at CT versus X-ray angiography, we understand our CTOs better. We understand their complexity better. The chances of predicting total success and guidewire crossing in 30 minutes is actually done better using a J-CTO score or CTO score derived from CT rather than X-ray angiography. So and that's because CT is done in steady state. When one injects 100 cc's of contrast, we can see the distal cap better than a quick pan to see the distal lumen filling by one angiogram. So in addition, it can look at bifurcations, it can look at the angle, it can look at calcium much better. So we do a better job understanding our actual target vessel. So we started asking the question, this was actually looked at many years ago, almost maybe 10 to 12 years ago, about real-time CT guidance, and there was a few anecdotes using wires to seeing if we could extract the center lines from the CT, map them on the X-ray system, and then have them rotate together. Could we do a better job? And there are a few anecdotes many years ago. Gerald Werner really looked at this some years ago and showed that we could get wires down, but the more complicated subsets had really not been explored. So we initially did a small study trying to understand whether or not if we did real-time display of the CT data, we extracted the center lines in calcium, placed them on top of the X-rays, whether or not we could do a better job to understand more complex CTO subsets. And we did this initially in about 24 patients, trying to understand a few things. And it was really a descriptive study, understanding how to use this technology effectively when the center lines are taken out by auto-segmentation, like similar to what we might use for TAVR extraction of the aorta on top of X-ray angiography. We could extract the center lines, we could extract the calcium, we can use different color codings to look at foreshortening, and we can do a better job to label calciums. We can turn off individual lines and focus just on our CTO segments. You'll see a little bit of misregistration, of course, because CT is done in a different setting than the actual procedure. Well, we found this is one example where we demonstrated, and this is just showing here that we can use an example to guide stingray delivery and maybe understand successes and failures. This was a post-cabbage case trying to re-enter in the distal right coronary. You can see the vein graft on the right, that's the center line extracted. When we had tried a stingray re-entry over a block of calcium, we had actually not been able to re-enter there. We hadn't realized we were over a piece of calcium until we looked at the CT, which clearly shows this very nice blooming artifact. In fact, when we went over to a successful site, we were in between two pieces of calcium. This raises the potential to intentionally try to guide our stingray balloons and reentry devices into non-calcified zones. This might be one application. So in the last half, I just wanted to mention two other potential applications, and we really think in the proximal cap ambiguity zone is really where CT guidance is going to offer some advantage. So this is a gentleman who had early graft failure and severe angina, daily nitroglycerin despite medical therapy. He had a ambiguous mid-right total occlusion. You can see here on the left side. You can see an RV marginal coming off good side, but where does the actual mid-right come off itself? That's hard to see. So we actually looked at the options for retrograde, and the epicardial collaterals were not really, I'm going to show that just one more time. Epicardial collaterals were not particularly attractive. We just discussed some of the complications from those. And the vein graft was stump occluded without a clear distal hood to get into the right PDA. So we looked at using CT guidance, and here is just an example of the overlay, and this really defines, this was the CT fusion, it defines where the true vessel is, where the RV marginal is. Now, if we want to be more aggressive about actually using stiffer wires and more intense strategies, we at least have some guidance. We're not just going blind down the mid-right coronary. And so this was a case where we took a wire that was stiff, used a blocking balloon in the RV marginal anchor. You'll see the stiff wire makes progress into the true cap. This segmentation can be moved on and off so it doesn't interfere when we're actually wiring. This stiff wire then made progress into the mid-right. Looks like it was taking the correct course, knuckled. This set up an antegrade dissection reentry approach that ultimately was successful with a stick and swap and led to multiple stents placed in a good result. So converting a potentially high-risk retrograde case into an antegrade dissection reentry case, and that was a useful application. Second case was to help guide a difficult flush occlusion of a right coronary ostium, and you saw some elegant work done by Jason. And what this was, it was difficult because it was a prior attempt. They'd actually gone through the epicardial native OM and the AV group circumflex there, but could not externalize. So we reattempted, and we were fortunate to be able to go down the vein graft itself this time, rather than going down the epicardial. We were able to ultimately knuckle back into the proximal cap, and so we initially tried to go antegrade. It was flush occluded, could not. Retrograde down the SVG, back up. Ultimately, we're able to knuckle and define the proximal cap. And we were unable to really get progress with stiff wires. We used Confianza Pro 12s, Hornet 14s, Estado 20s, and could not enter the aorta. You've heard some of these difficult challenges where you'll just ride up the sinus or go into the actual the aortic sinus or up the aorta. And so we decided to employ the ECART technique that that you had heard about from Jason just a moment ago. And one of the nice things about the ECART, we've heard of some cases where the wires can up in the pulmonary artery or in the right ventricle. It is nice to have the overlay to know exactly where the right coronary ostium is, especially if you can't get a guide to seat it. So you can use a pigtail, but you can also use the CT. And in this particular case, while I was confusing, that kind of straight line is pointing out into the aorta. Ultimately, this led to us feeling confident that we could use our electrical wire, and I think this was a turnpike that we used. It did not take 1 second, it took about 20 seconds. That was not fun to have to buzz that long, but ultimately it found the right course using Bill's techniques, and maybe using a fine cross might have been more efficient for delivering energy. So with that, this led to a reasonable result here. So ultimately, this is really a technique that we think is going to be helpful for understanding the CTO course. Tortuosity, calcium may improve our ability to really do more complicated procedures, particularly in proximal cap ambiguity, and there's other applications as well. And we're looking at trying to understand whether or not a multi-center trial to help us do more antegrade traversal in ambiguous caps would be useful. So with that, I'd like to thank my folks and colleagues, including Bobby, Bill, and Manos, and of course the sponsors and the organizers here for inviting me. Thanks so much.
Thank you so much, Farouc. I'm always fascinated by this and try to use it. Obviously, it's kind of, I think that what's the effect of the local expertise? What's your team who helps you do this amazing work?
Sure. So we've had a fantastic relationship with our radiologist. MGH Radiology has had a really strong interest in coronary CT from the beginning. So we certainly worked very closely with Brian Koshadra, is really our star in this and close colleague. So I've learned a lot working with him over the years. And over the years, it's become less dependent that we meet together. In the beginning, we were. One of my clinical research coordinators can segment this in about 15 minutes, and usually that allows us to kind of identify the key branches that we need to identify. It's just like any kind of practice-based approach. One can actually get good at it. There will be some techniques to sort of further improve the auto-segmentation, but with just getting used to the software, it's now a commercial product from Siemens. You don't have to do it in a research capacity. It's available. It takes about 10 to 15 minutes to segment.
So what hardware and software is needed? I know like some hospitals have the Siemens CT, some hospitals have the GE, some hospitals have the Philips. Are this technology available in all these or just particular technology?
So this is a Siemens-based system. Kind of conceptually, it could be done by any of the vendors. It really is just about extracting center lines and redisplaying them in kind of a common 3D space. But the Siemens modern generation systems all have this as a FDA-approved commercial package, just like TAVR segmentation or so forth. It does take a little bit more care to understand the limitations of CT and artifacts before just applying it, but it really is something that's quite learnable.
Yeah, because I went to my hospital in radiology and I asked them to do it, and it's like it didn't work. They did not understand my language, and so I wonder how could we build that knowledge base for between us and the radiologist.
The thing is, it's actually pretty agnostic to the CT scanner. It's not agnostic to the cath lab. So if you don't have a Siemens cath lab, we looked into this, and that was a big challenge. So you have to have a Siemens cath lab to make it do the overlay and make it work.
Yeah,
I think that's the big challenge. So if you don't, that's really key.
Farouc, could you comment on
any
the
CT scan, but that's exactly right.
value of CT for the invisible CTO? Is there any value there? You don't really see a target. Do CT scans help you know where to go?
We do, when patients, for example, have great symptoms in ischemia and they haven't had a great visualized targets, one of our indications is incomplete angiography. So we will certainly kind of request it in those situations. Every now and then that'll show up. Most of the time it is just a small, probably negatively remodeled target, underfilled, and we'll still try it. But like we saw earlier today, there might be an early conus to LAD collateral that wasn't selected. That sometimes shows up as a good target on CT.
Do you co-register those and use that while you're poking?
Do we co-register the
CT while you're sort of up there and trying to figure out where to go? Blind artery, stiff wire until you get a knuckle or something going. Those are ones that you can't see where you're going that cause a little bit of anxiety.
It certainly is great to know the course of the vessel if you're going to go totally blind. I think we try to we don't have so many cases now because we're doing such kind of more complete angiography with duals and large guides that we'll usually see our target. But there might be a gap of 30 millimeters, and it's nice to actually have the CT course defining that with calcium and wall. I think if you can avoid blind knuckle, even forgetting about getting going from proximal cap entry, just knuckling down the vessel of 30 to 40 millimeters, wires can go down RV marginals that weren't appreciated. They can go down the southern RV branches. And it's just great to actually have that course. You just get used to having it because it's a roadmap.
Great, thanks.
All right. So just kind of an audience, who is already performing routinely CTO PCIs in their lab? All right. Who is intending after the session to go perform CTO PCIs? No one. Of those who are performing CTO PCI, who's going to use the epicardial collaterals in the next 10 CTOs? So in closing, this is really very, very informative session to me, and I think I learned a lot from, but the CTO PCI is emerging and it's moving, and as Bill said, if you want to learn the technique, there are learning pathways. You can actually connect with any one of us here on the panel, and these learning pathways are available. Unfortunately, most of us did not train in fellowship to do CTO PCI, and I don't think I trained my interventional cardiology fellows to do CTO, although I expose them to it, but I still have, there are actually dedicated fellowship for it now, and there are partnership with industry that actually can provide you with a lot of help to develop the technique. But the most important thing when you face a CTO PCI, if the patient has an indication, at least there is an option for them If you don't want to do it, one of your partners in your city or next city can do it. Any comments, guys?
Yeah, I mean, you know, Bill said it best. Talk to the patient before you look at the angiogram. Decide up front whether they need revascularization, and then go figure out how to do it, or send them to someone that can do it comfortably and safely.
I guess the one comment for people in the room is, you know, as Cal was talking about, there's no fellowships. Everybody up here learned on the job. I will also say is everybody up on this panel gave something up to do that. Whether it was they don't do structural, they don't read echoes, they had to change jobs, they had to do other life events. You know, you can learn to do this. It's not easy, and it takes a lot of work, and nobody's going to give it to you. And it's not about success and failure. It's about learning and improving. And so if you have the right attitude and the right effort, there are people who want to help you be successful, but in the end, nobody's going to give this to you. It's not like saying, here's a technology you can now put in TAVRs, or here's the thing and you could do MitraClips. You're going to actually have to go out and really work hard and push yourself to get better. So you can do it if you want to put the work, time, and effort in to succeed.